If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? It's your man, Dr. Kyle. Welcome back to the Driven Athlete Podcast. We've been graced with the presence of Dr. Suzanne Fuchs with us. She's a doctor of podiatry medicine. She's a podiatrist, right?
Right.
Up in Jupiter. Mm-hmm. Well, I appreciate you coming in. I know you're busy. You're always on call. You always got patients going on. So I appreciate you coming in.
Thank you for having me. Sharing
some insights and sharing more of your story and what you do and like how you help people and your perspective and approach on some stuff. We want to dive in on like on what you do. So anyway, tell us where you're at. You're in Jupiter.
Sure. Yeah. My primary office is in Jupiter, Florida. We opened there I think it's been over 5 years, almost 6 years up there. I started when I moved from New York to Florida. I started in Palm Beach Gardens, which isn't far, but we moved up to Jupiter and we love it there.
Yeah. That's awesome.
Such a great part.
Where in New York?
Where?
Yeah, before in New York, where you at?
Oh, I was in, it was a big orthopedic group. It's a multi-specialty group, orthopedic. Okay. We were in the orthopedic department, sports medicine. It's called Pro Health on Long Island, like the North Shore of Long Island.
Oh, cool. How was that, Long Island?
Well, there were offices in Long Island, then there were offices in Manhattan. So it was kind of in between.
Gotcha.
A bunch of offices, lots of patients, one of those really big group practices.
Yeah, I'm sure like
we saw everything. Busy. Yeah. It was a great experience out of residency for about 5 years. And then I decided to make the move down here.
Cool. Yeah, I want to ask, so residency in podiatry, like surgery and sports, or what was your specialty?
So after podiatry school, so I went to Temple University in Philadelphia for podiatry school. And then right after that, I did a residency. I went back. I'm from New York originally. And then I got a great residency. It was called North Shore LIJ. It's now called Northwell. That is also in New York on Long Island and basically like Queens, Long Island border. And that was all surgical, mostly all surgical. We did some wound care, sports medicine, but mostly surgical. So that was a 3-year surgical residency after school.
Gotcha. And then you practiced there
And then I practiced in New York, in Manhattan, and on Long Island for about 4.5, 5 years.
And then you moved down here.
And then I moved down here.
Cool. And that's when you opened your practice.
And I just came down here, opened up a practice with a partner. We opened up pretty much cold. We wound up, without going into details, but we wound up just opening. We didn't buy practice from anybody. We just kind of knew the area a bit and just opened up. After it. 0 patients, and now we're here.
Cool. So. That's the same partner?
Yeah. No, that's another story. A different partner. It's much better now. We moved on, and it's worked out.
Yeah. I mean, you always want to grow and make moves, you know?
Yeah.
So you're from New York originally, Long Island?
I'm from Long Island. I grew up pretty much on Long Island, and then I moved away. I went to Pennsylvania for school for undergrad, and then for podiatry school. Yeah.
Where'd you go to undergrad?
University of Pittsburgh.
Oh, okay, yeah.
Yeah, cool. So I went to Pitt for undergrad, and that's where I decided.
Football games fun?
Football games. I was really more into the basketball at the time, but both.
Yeah, they've always been good.
Yeah, basketball was great.
They're like
so much fun.
I mean, they're always a formidable force, you know, men's and women's basketball.
Definitely.
That's cool.
Yeah, it was really fun. School, a great experience. But then when I got the residency in New York, I wound up going back to New York for the opportunity. But I loved Pennsylvania.
Cool. What made you go into DPM school? Pursue that route?
Yeah. So long story short, I was always interested in sports. I was thinking about physical therapy, occupational therapy, sports medicine. And I actually had a friend in school. Her uncle was a podiatrist, and she was really into podiatry. So I wound up shadowing a podiatrist. It was a woman. She owned her own practice, did sports, surgery. And that was kind of on and off for a few months, and I really enjoyed it. So
cool.
Yeah.
So that one experience, observation opportunity, and you're like, oh, this is cool. Yeah.
Yeah, it was just something, you can do. You can make people feel better right away and get them moving better, feeling better, whether it's an injection or in-office procedure or surgery, but, orthotics, better footwear. Just there's so many ways to, even just in your office, to have people feeling better immediately. So that kind of instant gratification was nice too.
Yeah, like get some results and buy-in day one.
Yeah.
Versus like going in the office, chatting, getting an image, and be like, okay, and then like
come back. Done. Exactly. Yeah. So I like to see people and then doing something or giving them something, whether it's in the office or something at home, to do to make them feel better, kind of, instantly. And some things take as you know, some things just take longer,
Yeah,
but at least to start feeling like they're on the right path.
Right, exactly. Yeah, like, oh, there's some hope, some encouragement. I was going to say, like, we were talking like just a minute ago about how we're similar practices that we're out of network, right? So we live and die off of our results we get with people, the word of mouth, and just the recommendations. Like, hey, they were great. I had a great experience, and what we can provide. And part of that being like day one, like trying hard and giving like an actual benefit and result that you can see, and be like, oh, hopefulness, encouragement, feeling better already. This makes sense.
Exactly.
I'm on board,
And especially like education, I can't tell you how many patients I see that come to me and they're like, nobody ever told me this. Nobody ever explained it to me this way. Because we're out of network. We have the time to actually explain to them their diagnosis, the root cause of it, and then the plan in detail. Most people don't remember more than maybe 30% of what the doctor tells them. But in our cases, we have some more time to make sure that they understand before they leave, which makes the whole treatment process
way better. Yeah, better results. Totally. No, that's awesome. I hear that all the time too. Like, nobody's ever told me this. I'm like, what? Well, like, think about it. Like, unfortunately, with a lot, they're very robust and busy healthcare practices. They don't have the time, and they're burnt out.
Sure,
they're worn out. They're hungry and tired, and like they're ready to get out of there. And they have like 50 more people to see. You know what I mean?
Oh yeah, that's what I tell everybody. I'm like, it's not. I'm not blaming them. It's actually just the nature of the beast of healthcare. Yeah. Unfortunately, that's kind of how it's going.
So that was so cool. That one experience with that podiatrist.
Yeah, it was just great. I really enjoyed it. I could see myself doing that, and I wound up applying to schools and going to visit schools and talking to some other people, and it just seemed to kind of fit what I wanted to do.
So sports medicine, did you, going into podiatry school, were you like, I don't want to be working with athletic?
I always had it in my mind. I mean, which was good. I mean, we were exposed to so many different things. Like I was saying, wound care. We do, and I still do, like skin care, nail care of the foot, ankle, legs. So I still do that. I do actually enjoy that part as well. And a lot of athletes will get ingrown toenails, like skin infections, athlete's foot, things like that. But I was exposed to so many different things, elective procedures like bunionectomies, hammer toes. But sports was always a passion of mine, and I knew pretty much that's kind of the path I want to do. But it did take time to develop that type of practice and to get the reputation. Yeah, totally. Yeah. So you kind of have to do whatever in the beginning, and it took time.
And you niche down.
Yeah.
It makes total sense. Like once you start doing what you've noticed, I'm sure it's very similar for you, like just crushing it, like doing a really great job, and then slowly building like a word of mouth and niching down, and then being known to be, and a reputation's built,
Exactly.
So why sports? Like, what was the motivation?
I've always been into sports, and for myself, I played field hockey in high school. I wound up not going to college for it, but I was recruited to go to school for it. I just decided not to focus more on academics. But I was always...
so field hockey.
Field hockey.
Cool. There's a lot of contact in that, right?
There's a lot of contact. I loved it. They wanted me to play lacrosse, but because there's some similarities. Yeah. So I was a midi, played midfield field hockey in high school, and I really enjoyed it. Cool. And then I saw a lot of the injuries. I had some injuries myself, like a lot of different ankle injuries, foot injuries. So I kind of was interested in that and how to prevent athletes from getting injured, how to heal more quickly, getting back to sports more quickly, and then more just like the longevity of actually staying in sports as you get older, which I've noticed over time. I've just become more interested in too. Older athletes still playing, because that's what you enjoy doing. I always liked working out and sports, not just for the physical aspect, but also the mental.
Oh, totally.
So, for me, my quality of life would be a lot less if I wasn't able to work out and be active in my life. Totally. So I wanted to keep people active. I felt it was very rewarding for myself.
Live vicariously through our patients.
Yeah, exactly.
That's super similar. Like I miss competing, of just like really getting after it and giving it all, being with a group of people that's on the same path as we're on the same, and then getting after it. Mm-hmm. With kids now, it's always, I can't just play pickup basketball and football and stuff. But and owning a practice, having a practice busy.
Oh,
but
yeah.
definitely miss that. And I live vicariously through a lot of the young patients that we see that in high school and college and stuff, and was like, yo, like there is a solution. You're not just like an anomaly for this musculoskeletal. Like we can fix this.
Right.
Just take some time. And like, I wish I would have known this stuff for the things I was battling when I was in college and high school and stuff.
Same.
So similar thing, And then for the aging athletes, the aging active weekend warrior people, a common question we get a lot or thing that we hear is they call us and they're like, I'm tired of being told to just not work out anymore. Or like, don't run, it's bad for you.
Right. Just
like, there's a shelf life. Just don't do anything now and your joints won't hurt, It's like you're doing something different that's causing the pain. Let's fix this root cause. And then you can get back to running again, exercising. You're like, really? I can? Like, I don't have to stop? Totally. It's actually good for you.
It's actually better not to just sit and do nothing for 6 weeks. Yeah.
Right, totally.
I tell people that all the time. Like, wait, after your surgery, you didn't move for 8 weeks? I'm like, that's so bad. Yeah. I mean, the number one thing is early mobilization after even a trauma, right? So to be sitting, when I see people and they're wondering why after their surgery, their big toe joint's stiff, and now they're having pain because of that, and their mobility is less than it was before the surgery. I'm just like, you didn't do physical therapy? Nobody gave you any exercises to? No, I've been sitting for 6 weeks, 8 weeks.
Just resting.
Yeah.
And like rest leads to rust.
Right. Exactly.
Motion's lotion. Let's get this thing going.
Yeah.
It is in a non-painful, non-aggressive way.
Yeah, of course. I mean, it depends on each case, but when they're ready to move, you should try to get them moving as soon as possible.
So what do you see most? Like, what are the biggest, most common things you see?
I mean, we see in terms of sports, we see sports injuries, ankle sprains, of course, Achilles tendonitis, tons of Achilles tendonitis, tendinosis, which is more just like acute on a chronic tear, degenerative, exactly. Speaking of degenerative, like a lot of osteoarthritis of the big toe joint, of the ankle, plantar fasciitis, I said, heel pain, heel spurs.
What about like posterior tib tendonitis?
Yeah, we see a lot of posterior tib, perineal tendonitis, tarsal tunnel, different nerve issues, neuromas, you name it. I mean, it's a pretty like broad practice, but I see a ton of Achilles, plantar fasciitis, posterior tib is a big one, flat feet, but actually high arches are more injury prone than flat feet.
Well, they're super stiff,
that cavus type foot, ankle sprains, stress fractures, hammer toes, bunions, plantar fasciitis.
Interesting. My something I battled when I was little, and my nephew now is battling this. He's 9, but he has heel pain right at the insertion of the Achilles. Okay. And I'm like, yo, it sounds like Sever's, right? What are your thoughts on or suggestions for Sever's?
Does he wear cleats? Does he?
Good question.
Does he?
I think he's
right. What does he play, or is he?
He's a swimmer.
He's a swimmer,
but he feels it when he runs and walks. So running, just like playing outside.
Yeah. I mean, so Sever. So basically, it's at the posterior heel. It's the growth plate, so it's not closed yet on him. So he may have that pain, inflammation on and off until the growth plate's fully closed. Yeah. But usually stretching exercises of the Achilles, the plantar fascia, calf stretches. You could use a heel cup. You could,
I remember having that when I was a kid.
Yeah.
Do you see this pretty often then with some youth athletes?
Yeah, a lot of kids get that. Boys and girls. I mean, even a high impact barefoot like gymnasts can get it too. Yeah. Sometimes I'll see ballet dancers, but I would say more than anything, it's cleats, like soccer.
Interesting. Yeah, totally. So that's like your wheelhouse. Like a lot of a plethora of diagnoses y'all see for active athletic people.
Yes.
And then you were mentioning earlier, so y'all do surgery.
Yeah, right.
But you're getting more into other regenerative, integrative therapies.
Yes.
And approaches. Yeah. So it's just like diving right into surgery right away.
Yeah. we try to exhaust all conservative therapies before surgery, which you really should do. Some people don't necessarily do that, but that's really how I look at treating foot, ankle, lower extremity disorders. So a lot of patients will come to us looking for another option, and they think they're out of options. I see so many people coming for a second opinion, third opinion, and they are looking for options other than surgery, at least to try to see. And so I do things like certain types of injectables. I think I was telling you before about exosomal injections, which are mesenchymal stem cells, which can help regenerate tissue, decrease scar tissue. It's very anti-inflammatory. We do it's like shockwave therapy, which I'm sure you've heard of for tendonitis, but it's a little bit, it uses sound waves instead. So it's called myofascial acoustic compression therapy. And it compresses tissue more than 5 times the amount as, say, a deep tissue massage. So it breaks down tissue. It's regenerative, helps bring circulation to the area, growth factors to the area to help heal tendons, ligaments, even joint. We've been using it for joints or neuropathic pain now. It's kind of off label for that, but it's it's a way to help improve pain without taking anti-inflammatories, steroid injections, or other types of medications. Of course, we do orthotics. We do laser therapy, infrared laser therapy, and we have some other techniques that we do in the office. But a lot of it is hands-on by the doctors. We don't have medical assistants doing it. It's always by myself or my partner. Those are some of the options.
That's really cool. And for like you mentioned you do like functional exams, like to check out the biomechanics of their foot, like where they're compensating.
We do full biomechanical exams on off weight bearing, on weight bearing. We do gait evaluations. We take video of the gait. Depending on their sport, we take video of them doing a golf swing or running outside, or we have them kind of tape themselves or record themselves. So we do a full exam. Usually our appointments are about 60 minutes for a new patient, especially an athlete. And that this way we're able to get to the root cause of the problem and then come up with the treatment plan.
The best action plan that fix the problem.
And usually it's not just one thing. It can be physical therapy with orthotics, or at home exercises, or we can show them some exercises to do. It's usually a combination of things. It's not just here's a pill, here's a cortisone injection, which I rarely give anymore, cortisone injections.
How come?
Well, it's actually been researched to show deterioration of tissue in whether you're injecting into a joint. It's more of a Band-Aid. It's more of a instant,
quick
anti-inflammatory, and sometimes it's necessary, but I don't really give a lot of those.
I've heard from some other professionals, they're like, we got like 2 free tokens with a steroid injection over a lifespan, of like, you're going to be fine. Nothing like 2 maybe. But it makes total sense. I don't hate injections. If someone's living in an agony and they can't live, it's like, get things to settle down, and then we can work on stuff when you're feeling better.
It's part of like a pain management protocol more than healing or regenerative therapy. It's not regenerative, but it is if we're managing pain. If somebody's in like a stage 4 condition, like a hallux rigidus stage 4, which is basically almost fused, right? Yeah. It's like their next option would be a fusion. So to manage, and they, for whatever reason, they don't want to do surgery or they can't right now, to manage the pain, that would be maybe a solution for something like that. But so many other things, I try to avoid it. Obviously you don't really, I remember, and I won't say who it was, but I remember being, in a college and kind of shadowing during residency and attending, and they were giving athletes, injections into tendons for pain and things like that.
Toradol?
You don't want to do that. It was a lot of steroid, actually,
Oh, wow. Okay.
And just tape them up and send them out. And I'm like,
get out there.
I want them to play. They're freshmen in college.
There was a athlete I've been working with that recently chronic knee issues. He also just had it was ACL surgery, but he's like almost a year out now. But anyway, he was getting better. We were working on some stuff. I was like, dude, we're in a good spot. Keep working on this stuff. And when you go to school this summer with the strength coach and the trainer and stuff like that, he called me like a month later after he left, and he was like, my knee is like way worse. And I was like, but you were pain free when we left. We were doing hot. We were doing good, like plyometric stuff with no pain. It was just weak. We did work on some stuff, build some strength. And now all of a sudden it's like way worse and more inflamed. And he's like, we were doing this. And he was just progressing too fast. And the solution that was suggested was to push through it.
Yeah.
So, just push through.
Yeah.
At some point, as a college athlete, you just need to like not be a baby and push through. And I'm like, okay, for certain things, if you're training and like muscle burn, like no pain, no gain. Yeah. And you got to do conditioning and it's hard. Totally.
Right.
But like injury rehab and like tendon issues, like that just leads to chronic lingering tendinosis. That's like never going away and lingering. I was like, oh man, that sucks. That's not the best, in my opinion, suggestion,
right?
For an athlete. But like, and also, by the way, just take more pain meds to mask what you're pushing through.
Sure, take an anti-inflammatory, and then that actually stops the healing process, right? So you need a little bit of inflammation, at least for the first day to 3 days,
right? And
then you just keep taking the anti-inflammatories, the steroids, keep pushing it. You're going to cause further damage.
What have you heard from Advil, or just I don't like to say brand names?
Yeah,
anti-inflammatory NSAIDs, non-steroidal anti-inflammatory.
Sure.
What are your
again, pain management. So I rarely tell people to take that. Like it's very, very rare that I take an anti-inflammatory, especially an oral, because that can cause a lot of GI issues. So if patients need a little bit of pain management while we start treatment, like you were saying before, even a steroid just to get you past that kind of hump of pain threshold.
Yeah.
I usually suggest like a topical anti-inflammatory. At least you could just use it locally. It's not affecting systemic issues.
Like Voltaren or?
Yeah, Voltaren. We can do compounds. I use like compound pharmacy that will make, depending on what the issue is, put a little bit of an anti-inflammatory, sometimes a nerve pain if it's there's like a nerve issue, like tarsal tunnel. Just to get them over that hump, I'd rather use a topical anti-inflammatory or pain med rather than an oral. But the oral, I would say really maybe like 5% of the time. It's mostly treatments like we do in our office, heat therapy, infrared, the piezo wave, physical therapy, ice heat. Like it's really, really rare that I'll prescribe it.
It's interesting. I'm hearing a lot of more healthcare practitioners and physicians like less the route of like, just take this over-the-counter NSAID, just good. A lot of the chronic issues that can arise, unforeseen,
Yeah, and
it's just interesting.
Yeah, it's not just locally because of the injury, but you could cause other
GI, liver.
Mm-hmm, exactly.
Totally, and the restricting of blood flow.
Yes.
So, what are the most challenging patients? Some of the cases that you see, what are the most challenging ones?
Sure. A lot of the challenging cases are the patients that have had surgery and have issues because of the surgery or recurrence of the problem. So I'll see like bunionectomies that maybe they walked too soon, something happened. I don't want to blame whoever it was, but they have a lot of times you'll see the stiffness of the first MPJ joint, the big toe joint. They'll come in, they're having worse pain than they had before the surgery. And so we'll treat that. We see like some severe, I don't see too many in the Jupiter practice, but before in residency or when I was working in New York, we would see like more severe cavus type foot deformities with really bad hammer toes, more severe bunions. The other severe like posterior tibial tendonitis, or not just tendonitis, but tendon dysfunction, where they really can't push off on the, or can't even do like a one limb heel raise. So that's one of the cases that we see that could be pretty bad.
Linger.
It can.
Posterior tib, like super sensitive.
Yeah.
Posterior tibial nerve, like right there, it's just very sensitive.
Yeah, the tarsal tunnel, everything.
So explain more for people, pes cavus and pes planus, like super high arch and super flat foot.
Yeah, so a pes cavus means a high arch foot. Usually they're rigid. They're usually a bit more rigid than, say, a flat foot. Pes planus means a flat foot, so it's more of like that pancake, when you step down, that kind of pancake foot. But a cavus or a high arch foot is... it's a lot less stable because there's not as much contact area or full contact surface area, right? So it's kind of like I usually tell patients a table with 3 legs instead of 4. So you're a lot less stability just overall, which can affect a lot of patients we see have come in and they don't even necessarily have foot problem, but they were referred because the physical therapist may have seen that their knee issues or their lower back or hip issues might be coming from their feet.
Downstream.
Yeah. So usually cavus feet, like I was saying before, they're prone to metatarsal stress fractures, hammer toes, because it's kind of utilizing the stability of the extensor and flexor tendons to kind of stabilize the foot. So it causes the toes to sort of grab the ground to balance. So hammer toes, bunions, plantar fasciitis, Achilles tendonitis, just because of the structure of the cavus foot, the way the talus sits in the ankle is just causes less range of motion of the ankle. So a lot of people have Achilles tendonitis, posterior heel spurs, Haglund's deformities. It's just, you name it.
Yeah.
Cavus foot's like the worst. I tell my patients like the worst foot to have. There was a podiatrist in New York that used to call it the, what did she call it? Like the aristocratic foot. So it's not a foot where you're supposed to just sit and not play sports and not be, hard labor, but the flat foot is a lot more stable. There's more shock absorption naturally because of pronation. You have increased, which is a good thing to pronate. Just some people pronate or roll in excessively. The posterior tibial tendon may not be functioning 100%, or it can be more of a bony structure. The subtalar joint is just over pronated, or the calcaneus is more everted. So the whole foot is rolling in, which causes, or the arch is rolling in rather, and the heel rolls in, which causes the feet to, like the forefoot to abduct, and actually can cause a anterior tilt in the pelvis. So some patients will come in with like lower back pain, sciatic pain.
Yeah.
And again, they may not have any foot pain at that time, but they went to their doctor and they saw that their feet are super flat. And they're like, oh, have you ever had this treated?
Yeah.
Maybe they saw them walk or just noticed it.
We find it, with our athletes, we definitely find a huge link between ankle issues, foot and ankle issues, and then upstream like low back and hip dysfunction.
Definitely.
Usually like a lot of like glute weakness, glute inhibition, and pelvic instability that then like the knees will compensate, and then just feeds more of an issue down the chain in the foot.
Yeah.
The arch collapse and like instability.
For sure.
But it's a super common thing, And I think
it's very common.
I'm always like, it's interesting is like, we find a lot of practitioners or some colleagues and stuff. They're like, so are you a foot up guy or a hip down to the foot guy? And I'm like, man, I'm either like both. Like,
you look at the whole picture.
Yeah, it doesn't really matter. Like, I think it's different, they all contribute, you know what I mean? They contribute. It's just a matter of like, what are we going to tackle first? Well, we're not going to neglect one thing or the other.
Sure.
But like, definitely can recognize like there's definitely a link and connection with foot issues and hip, low back instability, pelvic instability issues, and then down, vice versa.
Yeah, definitely.
But anyway, I think it's super important to like, we can't neglect that for athletes and active people.
No. And some people who maybe for whatever reason their focus in physical therapy wasn't on the whole person, or they really focus more on shoulder or the back, and they forget about the foot and ankle. And I think that can be a real big issue, because they'll fix one thing, like you said, up the chain, but they're not fixing the foundation. So to me, I'm looking at the whole person, but I'm definitely focusing on the foundation, which is the feet. So I always say, like,
what you do, it's your thing.
Yeah, like a house, if the foundation's off, the whole house is going to be off.
Yeah, totally.
So there's been plenty of times people have noticed that, even if they didn't have foot or ankle pain, and they sent their patients to me. I've even had somebody send for TMJ because they noticed their alignment was off, and then maybe one side, there was a limb length discrepancy coming from the pelvis and the foot, like one side was more pronated, one side was a little more supinated. Yeah. So we corrected that with orthotics, and their TMJ improved. So it was kind of interesting.
That's really interesting.
Yeah.
Did the dentist refer that person to you?
No, it was a physical therapist. It was somebody kind of like how you guys practice, and they noticed it. Yeah. That's and they're like, I wonder, just check to see if this would help.
Just check this out. Yeah.
Yeah.
Interesting. Okay, it was something you mentioned, tarsal tunnel, right? Is a pretty common thing that people bring up a lot. Explain that to listeners.
So I kind of explain, because a lot of people, they basically know carpal tunnel. A lot of people they know have had carpal tunnel. So there is we call it a retinaculum, which is like a structure that holds together the nerve, the vein. It's on the inside of the ankle, just like the wrist. And so that, it could be a neural tumor possibly that can cause tarsal tunnel, or it can be compression of the retinaculum. It's just really tight. There could be a lipoma in there. There could be some sort of cyst that's putting pressure on the nerve. So basically there's an issue with the nerve that supplies the tibial nerve, supplies the whole bottom part of the foot. So they can get burning, tingling, numbness type pain, or even like a sharp pain somewhere at the bottom of their foot, sometimes heel pain, or the inside of their ankle toward the bottom of the foot. Sometimes it could be shooting up as well. So we'll test, we do like some tests in our office, and if we can't necessarily get a full diagnosis and we need further testing, we'll do studies like an MRI, or sometimes we'll send them to a neurologist just to rule out anything. Usually we can tell between the in-office evaluation and possibly an MRI.
Gotcha.
But yeah, tarsal tunnel is just, it's compression of the nerve or damage to the nerve causing nerve type pain, numbness, tingling. Yeah.
So I'm sure people get maybe confused and like, oh, I got plantar fasciitis.
Yes.
Bottom of the foot pain.
It's
so
not always plantar fasciitis.
Wait, how do you differentiate and then explain that to
Sure.
patients?
It's well, the presentation can be different. Again, the type of pain they're feeling, and then the testing that we do in the office. There are certain tests like we call Tonell sign. It's basically like tapping on the inside of the ankle, and if they feel any numbness, tingling, or any type of nerve pain going up or down the foot, ankle, that could be a sign of it. For studies like an MRI study or nerve conduction studies, things like that.
Gotcha.
But you definitely want to rule that out. A lot of times, plantar fasciitis or heel pain can be from a heel spur. So if somebody has like more pinpoint pain on the plantar medial part of the calcaneus, and then you see the x-ray, there's a heel spur there, the plantar fascia is really tight, the Achilles is tight. I mean, usually we could tell. Sometimes people will give like we can give a diagnostic, like an injection just of some lidocaine to see if that helps, like
It relieves pain. Mm-hmm. Interesting. Yeah. What kind of patient profile do you find? A lot of plantar fasciitis versus a lot of tarsal tunnel?
Oh yeah. Plantar fasciitis is a lot more common than tarsal tunnel. And
What's
again,
the patient profile for those people?
For plantar fasciitis.
Yeah. You usually see.
It could be any. I mean, it is so common. Anybody can have it. I mean, from somebody who somebody who gained weight. I mean, we'll see people who they gain like 50 pounds in the last year, and they have a super flat foot, and they're wearing like flip flops all day, and they're putting a lot of extra pressure on their arch and their heel.
Yeah.
You know, a lot of people who overpronate can put a lot of stress on it. And again, with cavus as well, because that just makes it everything a lot tighter and less mobile. Yeah. So we can see that.
Pregnant women,
yeah, definitely pregnant.
Like gaining a bunch of weight real quick.
Yeah,
that makes sense.
Exactly. Like changing sport. Like if you start playing or running and you really never ran before, you don't wear appropriate shoes for your foot type. You're not doing you just start running and you don't do any strength training.
Progressions up to it.
Yeah, you don't do any stretching, any mobility. So we'll see that. Just people who walk barefoot a lot, we'll see that. Or some people can walk barefoot, but if you don't know the structure, you don't know that you're prone to certain issues, then it might not be the best.
Excessive undue pressure.
Exactly.
Totally. I feel like I've seen a lot of, it seems like women more so than men for plantar fasciitis that we've seen.
Really?
Maybe they're the only ones that actually reach out.
That could be.
And they're always like, fine, I don't need to go to the hospital.
Yeah, they'll take like a pill or
be good.
just be like,
just
I'll ignore it. I mean, in general, I think some male patients, not all, but some, when they have pain and they keep complaining after some time, their significant other or like
would you go,
parent,
please?
Sister, wife, they'll tell them like, just go to the doctor.
Yeah.
Or if they're already a patient of mine, they'll be like, I'm sending my husband to you. And then maybe 6 months later they come to me. But I think that could be why. Because I definitely see about 50-50 cases, but I think women are a little more proactive with going to the doctor.
Yeah, interesting. Yeah. What's like the best way you've noticed to treat, to get results for plantar fasciitis?
It's
an action plan.
Yeah, it really is an action plan. I mean, it's never, again, one thing. It's usually, let's assess I do a biomechanical after I get their foot type, their whole structure, their gait, and then I will find out I always have them bring their shoes in too, what shoes they're wearing most of the time, in the house, out of the house for sports. And then, so a lot of times it's not the appropriate shoes for them. So we'll start with that. I usually start very conservative. Then we'll start with a plan for mobility, some certain stretching exercises, strength, mobility exercises. I explain to them what mobility is. I'm like, it's like a deep tissue massage. You could do a foam roller, lacrosse ball, massage gun, but it's just basically getting the tissues moving. Then we can stretch, then we can warm up. Stretching is kind of secondary. Mobility is like super important, range of motion. So I start, like I said, very conservative, things they can do at home. Physical therapy sometimes may be necessary. A lot of times is necessary. And then we do, from there, might give them other options like the piezo wave therapy, the sound wave therapy, heat, icing. But heat is always, most people I see are not acutely inflamed. It's more of a chronic, or it could be an acute on a chronic problem. So most of the time I like heat over ice because it does help with blood flow, which that's where we're getting all the growth factors and the healing from. So it's very conservative. And then there's so many options, from night splints, orthotics, surgery is the last option. And I tell people like 99% of the time, I don't have to do surgery on folks with plantar fasciitis. It's very rare.
What would you do for that? Just like the debridement or like the heel spur?
There's a, you could open it up like a fasciotomy, but usually there's an endoscopic procedure, but that's inherently could be destabilizing because if you basically just cut part of the plantar fascia off of the plantar medial heel, right? So, I mean, it's rare, but if we try everything, including different types of injectables, we might have to go to that. But I probably do 0 to 1 a year because it's just not, I don't find it necessary for most patients.
Gotcha. It's super rare.
Yeah.
Interesting.
Yeah.
Something else that we get a lot of questions about, right, for us, because same population, right, active athletic people, and they're like, I want to keep work, I want to do this, I'm feeling better, and I want to integrate more workouts, I want to run, I'm feeling better, I can run now. It's like awesome. But I'm too busy. I'm too bad. I don't have time, right? I got kids, I'm at work, and I got, got other things going on in my house or whatever. So for you, because you're a busy individual, right? How do you best find to navigate your own schedule to still prioritize your own health, wellness, and fitness and nutrition and stuff? Like, what suggestions would you give people?
Sure.
What works for you?
Yeah, I like to keep to a routine, especially during the week. So normally I will try to exercise in the morning and kind of get that. For me, that works best is just
to get out of the way.
Getting out of the way. And then I'm the most, I just find it wakes me up. It puts me in a better mood, get the endorphins flowing. So usually in the morning.
Ready to tackle the day.
Yeah.
Where do you work out?
I either do it where I live at home or I go to a gym.
Smart. Yeah. Well, it's convenient.
Yeah, it's convenient. I try to do whatever's convenient. I mean, you can do so much at home. You could either, whether it's equipment or doing a YouTube video, yoga. I mean, there's so many options now.
A lot of options.
There's really no excuse. I mean, you can do an app for 20 minutes, I used to run more. I used to run outside more. I was doing 10Ks, half marathons. I never did a full, but
that's impressive though.
But if you just do that and you don't cross train, I was injuring myself. So I really focus on, as I've gotten older, I focus more on strength training. And strength training for not just for weight loss, but I tell patients, because I see older patients too, I see all ages. So it's really important for me as I get older to be able to be independent. Even when I'm hopefully 90 years old, able to get, sounds crazy, but just getting up out of a chair.
Totally.
Or going to the bathroom. I want to be independent. So having the strength and focusing on lower body, core, glutes, that type of thing, and to prevent injuries. So I focus on that. And then in terms of like nutrition, I definitely have like a routine. I focus on protein, making sure I get like as much clean protein. I'm drinking a lot of water, get not a lot of sugar, which really causes a lot of inflammation. Focusing more on micronutrients, getting enough like salt intake, not too much, but for me, it actually helps with sugar cravings. To hydrate, and it holds on to the water better. Just drinking water, you're going to go to the bathroom constantly. But so I focus on that.
Do you meal prep at all? Like, how do you navigate that? That's always hard.
Yeah, it's hard to meal prep. I kind of do. I have everything. I like to make smoothies kind of fresh every day, but I have everything ready to go. So I can just like add the protein, add the, add the blueberries, things like that.
So scheduling, getting in a routine, scheduling things out, what you like is consistent, and being consistent and then efficiency.
Exactly.
less resistance of like making things happen of like, oh, this gym is really far away, or like, well, I don't know what to do for a workout. It's like, yo, just YouTube something real quick.
Exactly.
So that's what you suggest.
Yeah. Or, have some weights in your house. You don't have to have like a full floor of different machines and weights. You could do body weight. You could have like a lightweight, medium, higher weight at home.
I still get a great effective
Yeah,
workout.
you could do so much. And walking is underrated. Just getting outside.
It's true.
I'll go for a walk, getting steps in, It's just moving, doing some weights, doing some stretching.
It's interesting, and I'm glad you said that a lot of resistance training, like strength training. So I hear like a lot of, especially females, right? They're like, well, I don't want to get bulky.
Right.
It's like, yo, you're not going to
No,
get
you're
bulky.
not gonna
The thing I always suggest to people is like,
do you know how hard it is to
it's hard to get bulky. Like there's dudes, like think about it like this, right? Men that are in their 20s and 30s. What is the number one goal if they're working out? They want to get big. They want to get jacked. They want to get Instagram jacked, right? Totally. And they work very hard and they still really can't get there. And they have like way more physiology set up to build muscle tissue and testosterone as well. And they're still having a hard time.
Right.
So you think you're going to outpace those, it's not going to happen. You know what I mean?
No.
But anyway, there's so much benefit to getting the strength training, versus just like long duration cardio, but balancing the two is definitely important. But
Sure.
So many more benefits with strength training, the muscle density, muscle tissue, development, and then protein to like supply the nutrients for the muscle growth.
And not to mention protecting your joints. I see so many people, even in their 60s already with spine issues with their back, and if they just strengthen their core a little bit, but their glute strength is like non-existent. I'm like, how's your core strength? I have them sometimes do other exercises just so I can see.
Yeah.
Like one leg hip thrusts and squats, and they can't do it. And I'm like, and you have no real muscle tone in your glutes. Like your hip stability is not there. But if they did that, maybe their back, especially a lot of lower back, L4, L5, S1.
Totally. Yeah. No, we crush that stuff all the time.
Yeah. That's great.
Like this might help your back pain.
Right.
Like, what?
Yeah. They're like,
Getting stronger.
I'm going to have to do this.
Yeah. Now I have to work out. Right. It's like you get to work out.
Exactly. You get to work out. And it's definitely a mindset. I think a lot of that is just getting yourself in that frame of mind. You can tell people so many times, but if they're not there yet, and I micromanage my patients. I
was going to say, how do you find the best result, to motivate and incentivize patients to be like, if you incorporate some of these exercises, some physical stuff.
Oh, that's a good question.
What do you usually say?
So I actually ask them what their goals are. Like what do they want out of this? Why are they here? What are their like long-term, short-term goals? Like where do they want to be? Do they want to walk like 3 miles? Not everybody has the same, everybody has different goals. Bike a certain amount, walk without pain for a mile. I mean, it could be something that we think isn't a big deal, but for them it is.
Yeah.
So I find that out and I'm like, look, if you don't do this, you won't be able to walk a mile without pain, or you won't be able to do the things that make you happy or pick up your granddaughter, things like that. So I kind of like put a little bit of fear in that this. Or also it kind of is a positive because it's like it could be life-changing. Because a month or two from now, I say like you'll be able to pick up your grandchild without pain, or you'll be able to go for a walk with your dog. You know?
Imagine being able to do that stuff without this bothering you. Would that be cool? Oh my God, that'd be amazing.
Right. Yeah.
It's like, great. Here's paint the picture. That sounds like you're painting a picture of like, incorporate these things. It's going to help you do that.
Exactly.
Of what you want ultimately. It's like, oh, now it makes sense. Now I'm bought in, Because
everybody, like I could think something's important, but if they don't, they're not going to listen. They're just going to tune me out. So I like to find out first what they think is important and
what they want.
Here. Yeah.
Yeah. And then tie it in with like everything else you need to do. Mm-hmm. I feel like we did it a lot because it's hard to future frame and project like imagine your shoulder in 8 weeks. We see this all the time. Like if you do these things, we're pretty confident and optimistic that you're going to get better. Right. And imagine if you do these things in a long enough time horizon, 6 weeks from now, if you were able to do overhead military press and then also throw the football or throw your baseball with your son and your shoulder didn't hurt. Like imagine that. Would that be cool?
Exactly.
Like, oh, that'd be awesome. Perfect.
Exactly.
Here's how we get there.
And giving them like that 6 weeks. And when they have that time in their head, it actually could make it, it could actually make it a lot easier.
Yeah, for sure.
It's realistic.
Something else that we've done, like, because I used to do a lot of personal training too, a while back. And for also patients, it's like, well, this is a longer term thing. Like, we got to work on this. Sometimes like, imagine like 12 weeks, right? Or like 16 weeks. I find it like they don't really get it. It's just difficult. Yeah. But I'm like, all right, what's the next holiday? All right, so imagine like Halloween. Imagine by Halloween, you're trick-or-treating and you're able to like give a high five because you got the best candy bar in the neighborhood and your shoulder doesn't hurt. Right. Or that, like Halloween, like, oh, that's more reachable.
Yeah.
That's reachable. That's chewable. I got it. Yeah. So like holidays, it seems to like grab it. It makes sense, for people sometimes.
Because they could picture it.
Yeah,
they
exactly.
have that picture in their mind and they have a goal and you're making it real for them. You have to make it real.
That's awesome. Well, I appreciate you coming in.
Yeah.
I know you're a busy person, like I said, and sharing your insights on a lot of these common diagnoses of foot issues and foot pain, like what it maybe looks like, and then the treatments that y'all do. If anybody has any questions or they want to reach out to you guys, what's the best way they can hit you up?
So our website is www.luxpodiatry, L-U-X-E, podiatry.com. We're on Instagram, Lux Podiatry. I'm on Instagram, Dr. Suz Heals, DrSuzheals. Dr. Suz Heals.
Yeah.
And exactly. It's kind of a play on words.
Yeah.
And
I see what you did there. Dr. Suz Heals.
Those are probably the best ways to get in touch. And our phone number and emails on there as well. So
cool. Okay, great.
Yeah.
Well, thanks for
having
in.
Me.
Yeah, totally.
It was fun.
And if y'all have any questions, like definitely don't hesitate to reach out. We're always open to suggestions, comments, questions, concerns, conflicting opinions, other ideas to do next. And if you're battling any issues that you feel like you want to chat with us, the best way to reach us is our phone number at 561-899-8725 or our administrative email, team@athleterc.com. And definitely reach out to Dr. Suz. Dr. Suz Heals. And if you have any questions, reach out and we'll catch y'all next time.